This is a state-of-the-art, minimally invasive OR. And what we have in the center, and this is why we're able to do this simulation-based training, is we have a human patient simulator, which is a Medi product. And what it does is it can read anesthetic gas. It understands what type of medications you can give them using a barcode type of technology. And right next to it is the green box there is a virtual reality machine. And it's by Symbionics. It's called the Lap Mentor. And it has the capability for a surgeon to perform a laparoscopic cholecystectomy, removal of a gallbladder. We have this quad screen technology where we can see what's going on in the room, what's going on with the patient, what's going on in the patient, in other words, how this operation is going to progress. And this also allows us to assess how people react to events that occur in the operating room, and then we will do what we call a debriefing afterwards. And we'll show them the quad screen, talk about events, talk about ways to improve teamwork, because the JCAHO, looking at events in the OR or events operating on the wrong patient, they found that over 70% of these are due to communication problems. The Institute of Medicine has talked about patient errors leading to about 98,000 deaths a year. They've also come out with a new guideline for how healthcare professionals should be educated. And one of their points is, one of the competencies they emphasize, is interdisciplinary team training. And that's what we're doing here today, combining our virtual reality technology, the human patient simulator technology, and the entire operating room team to help improve efficiency and teamwork and reduce patient errors and mistakes in the operating room.
This is Mr. Doe. Mr. Doe, I'm Dr. Morgan. I believe you've already met.
I'm Marjorie Everson, your nurse anesthetist.
And we're going to be putting you to sleep today. What sort of surgery are you going to have? Okay, gallbladder surgery. That's what we expected, John Doe. And we've looked at your chart. Doesn't look like you have any allergies. You don't have any loose teeth or false teeth. You're diabetic. You have high blood pressure. And you came in last night with a fever and belly pain.
A little bit of fentanyl to kind of help ease up some of that pain. I'm going to give you 2 cc's of that.
You feeling better? Good, I'm glad. When you wake up, you'll be in the recovery room. This will all be over, and you won't even know that they've started the surgery yet. I think he's asleep now.
Good. I'm going to give him 120 of a Nectine.
Great. He's stable. He's remarkably stable.
Yeah.
No problems he's had. You did a good job with this potassium last night.
Thank you. All right. Thank you.
All right, you ready?
Ready. Go ahead, Doc.
Can we do a timeout, please?
Yes.
Mr. John Doe for a laparoscopic cholecystectomy. Thank you.
That's right.
All right. I'm going to go ahead and start. Ready to insufflate?
Ready to All right. Go ahead, Doc. You want me to go ahead and put an OG tube in them?
Yeah, please.
Okay.
Insufflation starting. Thank you. Let me know when it hits 15. Okay.
Okay, can you stop your insufflation for a moment, because he's getting a little bradycardic.
Hit and stop.
Give him a little bit of 0.4 of Robenol.
Marge, you think I need to get Dr. Morgan in? Or
Let's give it a second, see if that Robenol works.
Okay.
I think we'll be okay. This happens pretty frequently. Give another, I'm going to have to give another hit of Robenol, so go ahead and call Dr. Morgan.
Okay.
Give another 0.4.
All right. Pressure's okay. Dr. Morgan?
Yes, pressure's fine. It's just that we don't want to insufflate him and cause even more bradycardia. Hey, Dr. Morgan, we've got a little bradycardia with insufflation. She stopped. I gave 0.4 Robenol, another 0.4. We're just waiting to see. I think that's a good idea. Yes, I do.
Why don't you give
That's in the form?
Give 0.2 milligrams.
Okay. 0.2 milligrams of atropine. Good.
Here we go.
Good.
Got nice clear breath sounds, too.
It'll be okay now.
All right, let's go. Thank you.
We'll watch it.
All right.
You want me to continue with
Please.
insufflation?
Please.
Ooh, we got a big gallbladder.
Yep. It needs to come out.
It's still a little low on the pressure. I think I'm going to give another 500 cc's of lactated bringers. We have plenty of fluid in the room, right?
We do.
Good.
Yeah,
Excellent.
he was a little dry.
Yeah, he's been throwing up. And I think I'm going to go ahead and move him up to 1.5% of SIVO now and give him a little anesthesia. Melinda, you know what? I didn't get my charge sheets. So whenever you have to go out by the desk, I'll take my charge sheets.
Okay. Is that all you need while I'm gone? A couple
So
labels
far.
or?
Yeah.
Okay.
That'd be great. You have to slow down here. Could you call Dr. Morgan? Our pressure's starting to fall.
Sure.
I'm going to open up the fluids. And go ahead and give a little bit of ephedrine.
Dr. Morgan, we need you.
Give 5 milligrams of ephedrine.
Everything okay up there?
Our pressure's dropping a little bit, so
How low?
it's 73/51. Yes, I gave 5 of ephedrine so far.
That should make a difference.
Yeah, it hasn't. I have my fluids wide open, and it looks like he's starting to have a few arrhythmias here, almost like an AFib.
I haven't committed to anything yet, so just let me know.
Another 5 of ephedrine, Doctor?
I would.
Okay. I'm going to give another 5 of ephedrine. It looks like he's trying to do a little something funny on there.
Looks like an atrial fit.
It does.
A rapid rate, rapid ventricular rate.
Yep.
How about some amiodarone?
Okay, I can get that.
That's
Well,
anything
now we're going into
everything's
VTAC.
Does he have a pulse?
Let me give some lidocaine, 100 milligrams. Okay. And we'll continue on with the amiodarone. Melinda, I think we need a set of labs on this.
Okay.
Okay, our lidocaine got him out. I'm going to continue on with this amiodarone low, though. Oh, now he's...
pulse.
You
Why don't
think...
you continue on with the amiodarone?
Okay. We might need to get the code card here, too.
Okay.
Code
Everything
cards
looks
will-
okay in here. I just checked.
Great.
There's no pulse. We're going to shock
No
him.
pulse.
Okay.
Charge it at 300.
I'm clear, you're clear, everybody's clear.
Okay. There we go. Looks like we have a sinus rhythm.
Good rhythm now. Pressure's back up.
Okay.
Good. Looks like we're a little elevated on his ST segment. Didn't you guys say you treated that potassium last night?
2.9.
And it's 3.6.
And
Look
we
in the chart.
started at 3.6 this morning?
Yeah.
How can
Yeah.
it be?
Let me grab the chart.
Yeah, please do, Melinda. I don't know what's going on. This could be the whole reason.
Yeah, now
What is
it
that?
looks like he may have had an intraoperative MI with that ST elevation.
Some nitroglycerin.
Okay.
Give him some nitroglycerin.
Do y'all have
and
potassium
put him on
here?
drip
Yeah.
as well.
I'm gonna give him 40 mics of nitric.
Didn't that say
Oh, he's
3.6?
back into. Hold on, he's back into
Okay,
VTAC.
here we go again.
Pulseless. He has no pulse.
Okay.
His labs are in there, Melinda?
Now, she's gonna have to help us shock right now before
All
she
right.
can look at those labs.
What are we going to charge to?
We're going to charge to 360.
Charging at 360.
I'm clear, you're clear, everybody's clear.
Okay.
No response.
Okay. Let me give another hit of lidocaine.
Okay.
Our amiodarone is in. We're just waiting for the to hang the drip.
We need to give a potassium drip as well. We need to get 20 milliequivalent here.
Okay. 100 of lidocaine in.
I'm clear, you're clear, everybody's clear.
Charging at 360.
Are we sure this is the right lab on the right patient here?
Um,
Yeah, this one is Jane Doe. I don't understand how her potassium
well,
is
this is
3.4
this is what we
morning.
have here. Potassium is
Look
3.6.
at this.
Oh, Jane Doe.
This is Jane Doe. We don't know what the potassium was when we started.
Okay, I'm going to give him 100 mics of Neo.
And I think the dopamine drip ought to be taking effect very soon.
Yeah.
Okay.
May have to go up to
This is about
7.
the best we're going to do until we
Yeah.
can remove
Let's get him over to ICU.
So let's go now.
We have a bed outside. and
Great. I need an ambu bag.
Called the nurse and we talked to the cardiologist.
Do we have our transport monitor?
I can't believe we didn't get the right lab work.
We're going to have to talk to floor nurses about that.
I'm amazed that none of us caught that.
We got pretty far with that.
Same last name.
Yeah.
That's what it is.
And I saw a J
Should have been a name alert on
instead
there.
of Joe.
We've got to find some way of preventing this from now on.
Yeah.
How was it?
It was real.
So did it really feel?
Yeah.
It was real.
Did you think that you were in a simulated environment, or did you? What made it real?
think
So I'll
having
start
the-
with
What made it real
Yeah.
was that we had all the instrumentation, the orders were real, everything that I had to process was real.
G.
Same. The simulators for me were quite real, as well as being able to notice the changes in the patient's vitals from the anesthesia standpoint, being able to constantly monitor that.
Did you feel like prepping, doing what you're prepping and stuff? Did that make it more like you
Yes.
kind of got in the mode? And
Yeah, having a gown and
draping?
glove and drape and everything, you actually start to think it's a real patient.